Hello, everybody. Welcome. It's a pleasure to be here with you today during our National Infertility Awareness Week. My name is Jill Attaman. I'm a reproductive endocrinologist and infertility specialist with Boston IVF. I have been practicing in the area since 2003 within New England, and it's a pleasure to be here today to talk to you about in vitro fertilization. Really, I think it's an IVF 101, the basics of IVF and in vitro fertilization, which is the process of taking eggs and sperm and combining them in a culture environment with the possible intention of placing an embryo back into a uterus at a later time. I think in order to understand in vitro fertilization, the best way to start is to really describe a menstrual cycle. And I'll do this as briefly as what I can. But during a normal menstrual cycle, a person will have a pituitary gland, which kind of sits here at the level of the nose. I always point to it, and I think that's a bad habit, but that is where the pituitary gland is found, secretes FSH, and that's follicle stimulating hormone. You're going to hear FSH again and again, so I do like to use some of the terminology just for teaching purposes. FSH is secreted to the ovary or ovaries and recruits follicles. So follicle stimulating hormone is very appropriately named. Follicles are the spaces in the ovaries where the eggs are resting and waiting. And those are eggs that a person may be born with that are used throughout a lifespan. FSH will allow multiple follicles to grow at once. So in a normal menstrual cycle, there may be a group of follicles that are 4 to 11 or even more that are being recruited, but one grows dominant in response to a variety of signals. Estrogen starts to rise as that egg gets larger than the follicle. And then, if it's possible, luteinizing hormone is secreted from the pituitary gland. This is the hormone that is detected in ovulation predictor kits. If anybody's ever tried to use ovulation predictor kits, it's LH, or luteinizing hormone. The process of in vitro fertilization is really designed just to overcome the normal body's mechanism to produce one egg at a time. So instead of one egg being recruited and becoming the dominant egg, a cohort or group of eggs that were there that could be responsive if given extra medications will try to grow, and those eggs are eventually retrieved. Fertilized with sperm. Sperm can be chosen from a partner, from a donor that is known or not known donor, a variety of different ways to fertilize eggs, and then embryos are developed in the culture environment. And then a person will come in for an embryo transfer for an embryo to be placed into a uterus. So there are a number of different steps in the actual in vitro fertilization process. The first may involve pre-treatment. Now, pre-treatment can come in the form of oral contraceptive pills, and it always sounds a little funny hearing that from a reproductive endocrinologist, but birth control pills have hormones in them that suppress some of those follicles to try to enhance synchrony of follicular development, so a group can grow at the same time. This may also happen with progesterone-only pills or with estrogen patches, also with oral estrogens, and sometimes an injection called an antagonist that will help decrease early growth of follicles. Follicles actually start growing in the menstrual cycle prior to the cycle that one person may be working with for the ovarian stimulation. Now, pre-treatment may or may not be recommended to you by your physician during discussions, but that may be part of the conversation. The next phase is the ovarian stimulation phase, and this is where an individual will use injections of hormones. These are hormones FSH, that follicle stimulating hormone, and then sometimes another hormone that looks just like LH or includes both LH and FSH. So it could be a different combination of medications. The dosage of medication also is dependent on who the individual is that's being stimulated, some of the pre-testing that's been done. These are discussions that you will have with a provider prior to an in vitro fertilization cycle. In general, somebody may be on injections of hormones for about 10 to 14 days. And these are small subcutaneous injections, which sometimes are a little tedious to think about, but they're just under the skin, a little bit like an insulin shot maybe. And they're used daily. An individual will come in for monitoring at different time schedules to make sure that the ovaries or ovary are responding to the injections. Ultrasounds occur. These are generally vaginal ultrasounds. They can be abdominal ultrasounds as well in certain situations. And then hormones are drawn. The hormone that is predominantly evaluated is estrogen, and this will help a physician look at an IVF cycle and say stimulation is going well, or the stimulation might need to be individualized for a particular person in a different way. Adjustments can be made. During the cycle, the estrogen levels will start to become quite high because that's the goal, is we're trying to recruit more than one follicle at a time. Anything that was originally available during that menstrual cycle is trying to get into that cohort and grow to have an egg eventually. That estrogen signal can be seen by the brain, and somebody could ovulate. That's called a premature ovulation prior to an egg retrieval. So medications used to try to prevent that. There are different medicines that are used. All of them act to try to prevent a person from having their own LH surge. So at some point during the cycle, somebody may be on up to 3 different types of medications, if not more. Eventually, once there are large follicles that are likely to contain mature eggs, a final medication is used to cause oocyte maturation. This would be the eggs maturing such that they are then floating around in a follicle. A follicle contains fluid. It's a little bit like a mini water balloon. And that egg is trying to detach from the wall of that water balloon and then hang out on the inside. 36 hours later, or anywhere from 35 to 38 hours later, depending on what you and your physician have talked about, an egg retrieval occurs. This is the next step in the process. The egg retrieval is typically done under anesthesia, so somebody's very comfortable during the process. Anesthesia is nice because there is a needle that's attached to the vaginal ultrasound. The needle enters through the vaginal wall and enters directly into the ovary, into the follicle itself. A little bit of negative pressure is exerted and that fluid is pulled back. It's collected into a little tube, and the embryologist is available there and waiting and will look to see if there's an egg that they can identify under a microscope. That egg is then kept warm in the embryology environment. Sperm is used that day. And again, the sperm source could be from multiple different places, depending on what the plan is. And sperm is then either surrounding an egg, or a sperm is injected into an egg, which is called ICSI. That's intracytoplasmic sperm injection. That may be recommended depending on particular scenarios. The next day, eggs are evaluated to see if they received sperm, and then placed in the or kept in the incubator for a number of days, up to 3 to 5 days later. On the 3rd day of development, there may be an early embryo, which has a small number of cells. Later on in the phase, around the 5th day, there may be 100 to 200 cells. Now, not every egg that's retrieved will be mature or available. Not every mature egg will fertilize. And there's a normal attrition that does happen in the process, because then we do need to watch and see if embryos will develop. Typically, an embryo transfer will then happen either around the 3rd or the 5th day, if that's the plan. This is where someone will come in. An embryo is gently placed into the uterus using a very small catheter. The catheter is, I joke a little bit, but I think it looks like a cooked spaghetti noodle. It's very small and very flexible, and it's a delicate procedure. Speculum is used to visualize the cervix. An ultrasound is then used over the abdomen with a full bladder. So it's a little uncomfortable. as somebody is visualizing that catheter being placed into the uterus. An embryo or embryos are placed into the uterus. If there are extra embryos, there's an option to cryopreserve embryos in the event that the first embryo transfer does not help with pregnancy, or if the plan is for cryopreservation from the start. Some individuals will opt for genetic testing of embryos, pre-implantation genetic testing, either for aneuploidy, which is number of chromosomes, for structural rearrangements to look at the chromosomes themselves, or for single gene disorders. Those embryos are generally cryopreserved and used for transfer at a later time after one is thawed. There is luteal phase support that's required after an embryo transfer. At some time, a physician would talk to you about using progesterone or measuring progesterone levels, making sure that there's enough hormone such that implantation can be successful. And there's a number of different protocols and ways to accomplish that for you, but somebody may be on medications for a number of weeks until things are successfully implanted. So that is my brief overview of in vitro fertilization. Clearly, I could talk about it for a very long time, but I know this is a Q&A, so I'd love to be able to get to the Q&A. So I'm going to go through some of these questions. And the first that I see is it possible to have an IVF for twins and decide on their gender? This question, in general, the goal is for a singleton or one pregnancy at a time, because that's going to be the healthiest type of pregnancy for an individual and for the pregnancy itself. So occasionally more than one embryo is transferred back to a uterus. Most of the time it's a single embryo transfer, but it does depend on age and particular patient characteristics and what somebody has gone through in the past. But most of the time it is one embryo. We do have national guidelines that are published from the American Society of Reproductive Medicine and that are available on their website as well for further reference. Can you decide on gender? Sex chromosomes can be revealed during a pre-implantation genetic testing phase. So this is when an embryo has 100 plus cells. It can be screened. A few cells can be removed from that embryo. Embryos are generally cryopreserved. The cells are sent to another embryology or another genetics laboratory that then analyzes the number of chromosomes, including what the sex chromosomes are. And different clinics have different policies as to how that information may or may not be disclosed or utilized by the clinic and by the patient. Not all sex chromosomes end up expressing the gender that we might expect based on the biological sex chromosomes, but those are conversations that you would have with an individual clinic and provider. All right, so the next question. What's better, a fresh or frozen embryo transfer? Thank you. Well, thank you for the question. Fresh and frozen embryo transfers are both very good options. It depends on particular circumstances. So not every individual will have embryos that can make it to a stage that would be cryopreserved, meaning embryos do need to do well in the culture environment. Eggs need to be mature, fertilized with sperm, cleave, develop, and be at a stage where they would be likely to survive a freeze and thaw process. If that's the case, a cryopreserved embryo that's then thawed does very well. Not everybody has embryos that can make it to that stage, in which case a fresh embryo transfer is also a very good option. So I would say that both are very good opportunities for pregnancy. There's not one that would be superior to another in a very generalized sense. I do think that is nice to individualize for an individual. All right, so the next question. What are the biggest challenges with IVF, specifically when dealing with low motility? And what do you recommend to overcome low motility? There are several challenges with IVF that I think that folks consider. There's a lot of anticipation with in vitro fertilization. It's a lot to go through. It's not the way that a lot of individuals have considered family building. It may be the way that everybody or somebody comes in saying, hey, this is how I know I'm going to need to become pregnant. But I think there are challenges in learning about the process, becoming familiar and comfortable with what's happening in a situation that feels very new. So I think there's a lot of anticipation there, a lot of expectation. Everybody wants somebody to do well, in particular you and your family that's building and your provider. And there are a lot of ups and downs that can be unanticipated, and things do happen with biology that are outside of our control. So I think those are some challenges that are less talked about. There are obvious challenges that can occur. Complications from procedures are rare, but they could happen. Sometimes embryos don't do as well. Specifically in regards to low motility, I generally recommend a couple of semen analyses to confirm that the motility is the baseline. A semen analysis can vary based on what an individual was exposed to in the few weeks prior to an ejaculation, for example. ICSI is a very nice way to overcome low motility if there's not another intervention prior to that. This is where sperm is used to inject directly into an egg. There are other options. Male reproductive urologists are great folks that we have available in many different regions to do good physical examinations, look at hormones, and see if there's a specific reason for low motility. But certainly, if that's present, having a couple of semen analyses are helpful, and just leading a healthy lifestyle is a good general rule of thumb. So anything that's good for you is generally good for reproduction. All right. The next question that I'll look at is, how does IVF implantation success rate differ between the first attempt and subsequent attempts? This is an excellent question. So each IVF cycle is evaluated. After an IVF cycle is complete, generally there is an appointment with a physician, and you review how things have gone during the cycle. There may be parts of an IVF cycle that would be altered based on what's learned during the first. In general, there's a very good opportunity or a similar opportunity in a subsequent IVF cycle, depending on what we're really learning. But with an IVF cycle in individuals that are less than 35, there's around a 50% probability, just roughly, of pregnancy occurring. Now, those numbers do change as individuals age, because that's the most important predictor of outcomes. The next question is referring to IUIs. So what is the rate of success for the first or second round of an intrauterine insemination? Intrauterine insemination is a little bit different than in vitro fertilization. This is a process where sperm is washed, placed into a catheter, and then concentrated into a small volume. That catheter is then placed into a uterine cavity. The rates of success will vary depending on the particular circumstances and if medications are used with an intrauterine insemination, if they're necessary. If somebody does not have prior exposure to sperm and needs exposure to sperm through an intrauterine insemination, the best probability of pregnancy is probably 20-ish%, which is around what it would be for somebody who is on the younger reproductive age and having exposure to sperm. Otherwise, if it's unexplained infertility where there's egg and sperm and there's been a year of attempts in somebody who's under 35, for example, the probability is lower. It's probably around 10 to 12% in general. Those numbers can be a little bit better individualized for you, but the first is around the same as the second for most individuals under most circumstances. The next question, are these hormones injected bad for the ovary? The injected hormones that are used during in vitro fertilization are the hormones that the ovary normally sees during a normal menstrual cycle. They're given in higher amounts. And these hormones are not generally considered bad for an ovary. There are side effects that can happen from hormones and extra hormones. These include ovarian hyperstimulation. This is when the ovaries do see a lot of hormones and start to secrete substances that act at the blood vessels and leak fluid from the blood vessels into the pelvis and lungs, and that can make one sick. That's called ovarian hyperstimulation. That is being monitored during the IVF cycle through blood work and ultrasound. Let's see. Next, to have a successful transfer for somebody walking around 2,000 steps a day, is it recommended to rest during the day leading to transfer and after transfer, or walk 3 to 5 miles a day? Love walking, love movement. I think movement is amazing. It's great for you, good for general health, good for fertility because of that reason. Your ovaries may feel a little bit big and bloated. If your ovaries have been very responsive, I would say a nice gentle walk would be advisable. Nothing vigorous the day of transfer, the day leading into retrieval, day after. We generally tell you to try to take good care of yourself. It doesn't mean you can't go on a walk, but if you're not meeting your daily step requirement for those few days, I think that's probably okay too. Next question is egg retrieval and implantation done in the same month? This can be done in the same month. For somebody that's doing a fresh embryo transfer, meaning undergoing ovarian hyperstimulation, retrieval, allowing embryos to grow in the culture dish for 3 to 5 days, and then planning to place them back into the uterus, yes, that can be done in the same cycle, and that's a very common way to proceed with in vitro fertilization. What are the factors considered to determine if an embryo can be cryopreserved or need to be transferred fresh? This is the next question. The embryologists that work with the embryos in the embryology lab are very well experienced and skilled at looking at embryos and grading them for size, number of cells, symmetry of cells, and any degree of fragmentation. This is how they are determined whether they can survive the freeze and the subsequent thaw cycle and potentially a viable pregnancy for somebody in the future. Different embryology laboratories do have different criteria. A fresh transfer is something that's really determined generally prior to the cycle itself, whether it's what you are hoping for as an individual for fresh transfer, that can be determined despite the grading system. As long as that embryo is divided and doing well, it can be transferred. All right. Can you talk about using donor sperm? Absolutely. Does it change the process at all? Anything to be aware of going in if donor sperm would be used? Now, this is a really nice segue because one of my amazing colleagues is going to be talking about LGBTQ plus family building in our immediate follow-up in about 5 minutes. But yes, absolutely, you can use donor sperm, partner sperm. There are different ways to use donor sperm. Some individuals have a directed donor, somebody they know that wants to donate sperm to them. And there's a process that we go through to ensure that intended parentage is well delineated and that the sperm is healthy and a good match for an individual. There's also sperm banks where you can purchase sperm, and the process itself is essentially the same. All right, next question. What month is good to travel after IVF? Yeah, it's nice to be able to travel. Traveling is fantastic. It's one of my passions. It depends. So you're likely would not want to travel prior to your next menstrual period, just to allow ovaries time to get back to a normal stage. However, if you're waiting for pregnancy testing, or early pregnancy ultrasounds, that can make travel a little challenging. So I would definitely talk to your primary team about that. If pregnancy is the goal, then you can travel during pregnancy, but I always recommend that you have good trip insurance, just so that you're well covered and you know how to get medical care if for some reason you needed to. Things can happen with pregnancies, so it's always a good idea. But enjoy your travel. Hopefully that happens. All right, so I know that this half hour has flown by and there are a lot of great questions. I'd love to be able to address more, but I also want to give time to log off so that you can immediately log into the next Q&A. And I want to thank you for your time. I am here for you. If there's anything that you need, please do reach out. It is a pleasure, and I wish everybody the best success in what their goals are with their reproductive health and or family building. Thank you so much.